So today's my intention would be to look at some neuro-ophthalmologic pathways and try to sort out few difficult topics that you usually encounter when you actually go through both neurology as well as ophthalmology. So this is gonna be a bit difficult as well as it requires very intuitive knowledge about everything, both the physiology as well as the anatomy as well. But we'll be trying to look at it in a very clinical perspective so that it will help you to diagnose problems as well as to identify them, to nomenclature them, and also to improve your clinical skills as well. So this is it. It's going to be a bit difficult. That's something that I'm going to assure you. But still, try to find out a little bit of a notion where you can find these changes as well as define the problems that are associated, and try to define them using your basic knowledge. Right, here we go. So first, before going to anything, I would initially start with something very difficult that most of you guys might find something common in your clinical practice, but still bit difficult to understand and to uh, give a actual clarification about the problem. So yes, nystagmus. What does nystagmus means? Right. So before starting, first of all, the definition of nystagmus is quite important. It actually says about a it says about a rhythmic oscillatory motion of the eyes which is more or less regular. So this is the actual definition. You would see different types of nystagmus in most people. Now, some of them are actually hidden, whereas some hidden means they are latent, and some of them are quite visible and prominent. Now, we can um, first of all, classification of nystagmus could be done either it could be physiological or pathological. Now, physiological, there are a few types that you come across. Now, one thing that you already know is that uh, it is usually seen at end gazes. It could be up, down, right, left, anywhere at the terminal state of the end gaze, you would see a nystagmus. Then the other one would be when they are focusing on stripes in stripes. So both usually what happens is that eye tries to focus in to a particular stripe, but it gets dislodged once you move the eye from one position to another, and it suddenly tries to oscillate to bring into focus the particular stripe that you were already focusing on. So this leads to nystagmus. That's quite trivial and it doesn't require any attention. And then the other physiological type would be the vestibular one. Vestibular means now um, there are certain the vestibular organ is constantly in communication with the eyes. This actually there is a reflex as well, which is known as the vestibular ocular reflex. The vestibular complex, which is actually the nerve fibers coming from the utricule and also a few from the semicircular canals as well as the saccule, will be communicating with uh, uh, all the third, fourth cranial nerves as well as the sixth as well, in order to maintain this balance and everything. But uh, due to certain conditions, such as, let's assume that you are pouring in this is seen in certain physiological circumstances, whereas you see when you pour cold water you would see that there is a nystagmus usually towards the opposite side. So that and also if you are pouring warm water, the nystagmus, the fast phase of the nystagmus, it will happen in both directions. But what I'm saying is that the fast phase of the nystagmus usually will be to the same side. So there comes our mnemonic, which you might already might have come across this in your physiology. It is COBS, which means now this is a vestibulo-ocular reflex. Once you pour cold water, you would see a fast phase of a nystagmus towards the opposite side, whereas warm water will trigger a nystagmus towards the same side. So it's still very trivial stuff, doesn't require much of an attention. These are normal. Yeah. Then we go to the pathological stuff. I'm not going into detail, but I'm trying to bring this very uh, elementary as possible. Right. So there are congenital nystagmus, which is seen in some pediatric patients. Now, this could be due to a sensory deprivation, which means now due to certain aspect, the visual pathway is not working well, which means now there will be, it is not complete, the patient is not completely blind, but has difficulty in conducting these sensory information. So what happens is that in these circumstances, this could be, there are multiple occasions where you see this. This could be albinisms, this could be Leber's congenital amaurosis, it could also be optic nerve hyperplasia, or even a monochromatism. So any sort of a sensory deprivation may lead to a certain nystagmus. Usually this is pendular, but sort of a thing that you see in a pediatric patient. And sometimes you see latent sort of nystagmus. Latent means it is not very prominent, but when you cover one eye, you would see a nystagmus in the other. This is usually seen in patients who have a better working eye than the other, which means now they are more or less having a higher penchant towards having monocular vision rather than binocular, which means one of the eye is working well other than the other. Therefore, most of the work is done by one eye. Hence, once this is covered, there will be certain sort of a nystagmus that you could see. So this is called a latent nystagmus. So what you have to do is that, first of all, see whether there is any nystagmus during eye movements. If not, cover one eye and see. If that particular change triggers a nystagmus, then you should know that it is a latent one, and the visual acuity might not be the same for both the eyes. Are we good? So that is again a congenital nystagmus that we come across. In addition to that, you might also see this bit of a fancy term. It is called spasm Newton syndrome. Now, what does this mean? Uh, Usually, sometimes there are children with torticollis, which means that the head is tilted to a single side. So their vision is also disrupted in such positional changes. So their eyes will not work or coalesce together in vision. Therefore, they would sometimes, when once the head position is changed from one to another, there is a possibility you would appreciate nystagmus from happening. So this is called spasm nutans. Again, something seen in pediatrics. So you know now there are three types of nystagmus that you can comprehend in pediatric patients. This could either be a sensory deprivation or a latent one, which means now the patient is having a monocular vision, or else already the patient is having a torticollis, which has led to a nystagmus, which is called spasm nutans. Are we good? Yeah. Then you get the acquired conditions. The acquired conditions are bit pathology. I mean, it requires attention of an ophthalmologist. Right. The first one, the nystagmus could be triggered once the patient is looking down. It is called a downbeat one, a downbeat nystagmus. The downbeat nystagmus is usually caused, now if you can remember your physiology, the upward and the downward gaze is more or less conducted by or carried out by the midbrain. So if there's some sort of a problem in the brain stem or the midbrain, there is a possibility that it can cause a little bit of a nystagmus when moving up or down. So in this case, usually the downbeat is caused by any problems in the cervico-medullary region, or else there is another congenital condition which is known as Arnold-Chiari malformation. If you are very keen, you can actually go through this Arnold-Chiari malformation, which can lead to certain dissociations in the brain stem, as well as because of the dissociated and the disrupted structure of the brain. It is actually because of the enhanced ventricles and the hyperplasia of the cerebellum. But still, this Arnold-Chiari malformation can cause a downbeat. So if there's a downbeat, you should know that this has something to do with these two conditions. If there's an upbeat, upward beat or an nystagmus when looking up, then it is a problem either that is involving the vermis of the pons, because again, as I said, now the looking up and down is usually carried out by these brain stem regions, particularly the midbrain, as well as, so it helps the cerebellum and the pons helps as well. So this causes a problem in the vermis of the, not the pons, I'm sorry, it's a cerebellum, vermis of the cerebellum. So vermis of the cerebellum. In So upward beat. Apart from that, can also be triggered by the administration of a certain medication which is called phenytoin. Not very keen on that, but still you should know this. Right. Then there are the then you come across then there are the gaze evoked nystagmus. When you try to perceive an object, then the nystagmus actually comes. This is a problem with the brain stem, or particularly the brain stem. So if there's a gaze evoked nystagmus, it might be a problem in the brain stem. And the other thing that we can look is a gaze paratic nystagmus, which means now the gaze evoked means when you are trying to move or fix your vision on a particular object. But if the gaze paratic nystagmus means when once you are staying still, there is a nystagmus that is triggered. So this is usually a cerebellar lesion, gaze paratic. Right. In addition to this, you might also see a certain nystagmus which is called seesaw nystagmus. This is it's like a seesaw, which means now there is one eye which is moving down, whereas the other eye moves up. Again, once these movements takes place, you see a sort of a saccadic nystagmus like motion. So seesaw is, if you can remember, uh, these motions are somewhat carried out by the third and the fourth cranial nerve. The third, which gives rise to which conducts the motion of the inferior oblique, which causes extorsion, and then the superior oblique that causes intorsion, that is in fact controlled by the fourth cranial nerve. So these are the ones which has to be involved. So you see that there is a problem in the midbrain. So what you see is that a closely associated structure that you see in the midbrain and the brainstem would be the third ventricle. So certain lesions that happening close to this third ventricle, which in fact the paracellular region, will lead to this problem. So seesaw nystagmus is seen once there are paracellular lesions close to the third ventricle. Right. So it could be an upward beat, a downward beat, a gaze evoked or a gaze paratic nystagmus, or a seesaw nystagmus. So there are many more. If you can, if you go through, the nystagmus is actually a lesson that has to be done exclusively in a very detailed manner, but I'm just looking at few things that you should know and could pick up in your day-to-day clinical practice. So another thing would be there's something called the minus nystagmus, which means now once people are very acclimatized to or works in a very dim light, what happens is that when they go to a more brighter or illuminated state, they will show few nystagmus which happens bilaterally. So that is minus nystagmus. This name actually came because when coal miners usually work in a dim light. And there are also ataxic nystagmus, which means now the in particularly in horizontal gaze, the eyes are not working well with one another. Especially this happens in multiple sclerosis, in internuclear ophthalmology. I'll be looking at this in a very broad manner, but know that there is something called ataxic nystagmus as well. Apart from that, there are a few others as well which I'm not going to discuss. So this is something that you can remember and take into account if you come across a patient who has nystagmus. So bit of a tough one, but still I think that you have got a little bit of an understanding. So the acquired conditions, you should ask the patient to look sideways and up and see whether there is any sort of a nystagmus that you can pick up. If you pick up if you pick up upward beat or downward beat, then you know what the problem is. Or else it could also be a gaze evoked nystagmus. Once you're moving horizontally, you see nystagmus from happening, and a gaze paratic one once it is fixed in a certain position. Or else it could be a seesaw one as well. So this is what I usually go through when it comes to nystagmus, but there are many more. There is also something called convergence restriction nystagmus, which I'll be not looking today, but perhaps we'll give you a good explanation in an upcoming video, right? Then I look at squints. Squints means now the eyes are not present in a very now usually the eyes should be present in the midline position, but sometimes this is not so. Sometimes one of the eyes could be present in a very awkward position. This in lay terms what we call is a lazy eye. Now there are few types of squints. Squints happens because it has something to do with the cranial nerves, which are cranial nerves that are involved in innervating the extraocular muscles. If they are by some means not working properly, there will be disalignment of the eyes. So how do we actually identify the squints? Now it's something like this. The two terms that you need to remember is there's something called tropio, which means it is prominent. You can see it directly without any maneuvers. Tropio. Or else it could be latent, uh, which is called phobio, afraid like. So a latent squint can only be identified if the particular eye, if the normal eye is covered. Once normal eye is covered. If it is not covered, what would happen is that the normal eye would compensate for the problematic eye, and then you wouldn't see a squint. So tropio means actually you can see it whenever there is no need of closure of the eyes, but if it is phobio or a latent one, you have to close the normal eye. Now this is again nomenclature according to the fact whether it is present, whether it has gone medially or in an outward manner. If it has gone medially, it is given the name isotropia, or else it is given the name exotropia. So easy as that. So whenever you come across a patient who has a squint or it relates about certain diplopia as well as some um, visual visual cannot say deterioration, but sort of a reduction in visual acuity, you should also see whether the patient has a squint. Most of the times the squints are because of refractory errors. You can prescribe lenses or else spectacles in order to make sure that the squint actually goes down. But the thing is, if it is visible to the naked eye without any menus, it is called tropio. Whereas if it is not, you have to cover both eyes in an alternate manner and see whether the other eye shows some sort of a disalignment through the menu. So then that is called latent, and then you can, according to the disalignment, whether it's medial, you can term it as isotropia or as exotropia. So this is squints. So what else? Then I would like to start with, now I have gone through nystagmus, I have gone through squints. Now the other most important one would be the pupils. Right. So pupils. Now you look at the pupils in a very, if there are in a very close manner, if there are changes or if there are, now let's assume this is the pupil, both has to be similar. So if there are any changes in the pupils, you should know that this has something to do with the nerves which are actually innervating the pupils. Now, if you can remember your physiology, the pupils has radial muscles and circular muscles. The radial muscles causes dilation, which is innervated by the sympathetic nerves. The sympathetic nerves, which actually comes through the short ciliary nerve. So sympathetic, short ciliary. The circular muscles causes constriction. It is somewhat under the control of parasympathetic fibers, and the fibers usually comes with the third cranial nerve in the long ciliary nerve. Right. So this is it. Third cranial nerve. It branches out and with the long ciliary nerve, which actually innervates the circular muscles. So the circular muscles causes miosis, which means constriction of the pupils. Now, if there is a difference between the two pupils, we term it as anisocoria. Any difference, any distinct change between the sizes of the pupils. Right. So if you see an anisocoria, then you should think about few conditions. I'll jump directly to the conditions. Then that's how you can improve your clinical skills. So if there's a difference, then you should know there are few conditions that might lead to this. It could be these are very famous, but most of the time, most people do not know what the condition relates to. So there's something called Ades tonic reflex. Ades tonic pupil. Now, in a Ades tonic pupil, what has happened is that it usually happens due to tumors, infections, particularly infections. It could be CBV, EMV, many viral diseases that can lead to this. So, in Ades tonic pupil, you would see a unilateral dilated eye. A unilateral dilated eye. So anisocoria, which because of one nerve is not one eye is actually dilated. So in this case, you would like to see, now if you see such a difference, one eye being dilated, you would immediately, what you have to do is that you have to see whether um, what would happen to the eyes in accommodation? Usually in near vision, you see the eyes usually constricts. That's the uh, normal mechanism that happens. But in this patient, if the unilateral dilated eye shows constriction when focusing onto a nearby object, then there is a dissociation between the light reflexes and the near accommodation reflexes. So this the term that you usually give is a light near dissociation. So difference to light and accommodation, light near dissociation. So in this case, now you know that this has something to do with the unilateral dilated eye is because now the sympathetic nerve or the short ciliary nerve that causes I'm sorry, the long ciliary nerve that causes meiosis is somewhat disrupted to a particular eye, to a unilateral eye. So in this case, if there's light near dissociation, if one is working, the near vision is working, but still not the uh, not not the light reflex, then you should know that this has something to do with the parasympathetics that are coming to the circular muscles of the pupil. Then this is given this you can come to a conclusion that this is actually a AD's tonic pupil, AD tonic pupil with a unilateral dilated eye. The problem is in the ciliary ganglion, which gives rise to the parasympathetic nerves that leads to meiosis. So it is not working. The, the other close problem that goes similar to this is, which has again light near dissociation, but usually happens in a bilateral manner, is the Argyll-Robertson pupil. What does what disease cause Argyll-Robertson? It happens, this is unilateral, whereas Argyll-Robertson is bilateral. Both causes problems in the parasympathetics, which causes meiosis. So both leads to dilated eye, and it has light near dissociation because the near the accommodation reflexes are not altered because the parasympathetics the near the muscles that are working with near vision is the pathway is preserved in this case. So Argyll-Robertson leads to bilateral dilations. This is due to neurosyphilis or third stage of syphilis. So neurosyphilis. Are we clear? So if you see an anisocoria, if there's preserved near accommodation, so there's light near dissociation. If it is unilateral, you can come to a conclusion it is adhestonic pupil. If not, if it is bilateral, then more or less you have a better diagnosis, which would be neurosyphilis leading to an Argyll-Robertson pupil. Are we clear? So this could also be a pharmacological problem, but uh, in case if we want to dilate an eye, if we add certain uh, what do you call this dilatory agents, what would happen is that the eye itself would be dilated. But in pharmacological perspectives, this could be reversed. How so? It could be reversed by pilocarpine. I'm sorry. In pharmacological, this cannot be reversed because now already cannot be reversed. I'm sorry, cannot be reversed. Why is that? Now you have already added an agent which has caused the dilation, and so if you add another agent for the parasympathetics to work, it will not have an impact. So you can differentiate adystonic pupil from adystonic as well as the Argyll-Robertson. From Argyll-Robertson, of course, will not work well, but adystonic pupil uh, from the pharmacological mydriasis by means of adding a constrictory agent or a agent that will trigger the action of the parasympathetics. In this case, this is pilocarpine. You can add pilocarpine in different concentrations. Initially, you try with 0.1%. This will work for the editonic pupil and you would not see the anisocoria. You can increase the concentration up to 1%. Even with 1%, if it is not working, then of course this is an eye which has been dilated by addition of a certain chemical agent. Are we clear? Right. This is what you should know about the pupils. There are a few other aspects as well. Usually, if you can remember, in uncus herniation, what happens is that it will compress the bilateral third cranial nerve. So, which carries the parasympathetics. Therefore, there will be a bilateral dilation. This is known as the Hutchison's pupil. Hutchison's pupil. So, if you see a dilated sort of an eye with a patient who has already undergone some sort of a brain trauma or who has undergone some sort of a trauma event, you should know that there is a possibility that it could be or EDH or a SDH that might be leading to a imminent uncus herniation. Are we clear? Initially, what happens is that when the uncus starts herniating, when it goes down and comes closer to the brain stem region, what it does that it irritates the third cranial nerve, either unilaterally or bilaterally. If it is it could be both unilateral or bilateral. So because now unilateral itself. If it happens in a single in a more or less a unilateral way, what would happen is that only one of the third cranial nerves will be uh, disrupted, whereas if it happens bilaterally, of course both will be involved in this problem. So what happens is that with uncus herniation, there will be disruption of the third cranial nerve, which initially leads to irritation. The irritation causes overactivity. The overactivity causes a sort of a momentary constriction of the pupil. But later on, it will completely compress the third cranial nerve, causes neuropraxia. Therefore, it will go to a dilation. So this is the Hutchison's pupil that you come across. So patient coming in to the traumatic center who has already fallen down and has had some sort of a brain injury or a head injury, you should be vigilant about the fact that there could be an uncus herniation happening. Right. What else? So these are the three things that I usually want to speak about when it comes to pupils. But in addition to that, there is something also called Wernicke hemianopic pupil. Uh, Perhaps it's not the best. I'll not elaborate on it much, but because now already you might have quite a lot in regards of pupils. So now comes uh, the more what do you call this? This is something that usually students fails to understand. So there's something called relative afferent pupillary defect. What is this? Now, once you shine a light to one of the eyes, what would happen is that it would constrict. This is called the direct reflex. But what should happen is that now let's assume this is the right eye, so this is the left eye. Now you are shining a light to the right eye. It is conducted through the optic nerve and it crosses in the optic chiasma, and this is the afferent pathway. So it comes to the lateral geniculate body LGB, and there's another nerve which is conducted to the Edding-Westphal nucleus, which is present in the midbrain, and later on it will be it will send information to the third cranial nerve of the contralateral eye to cause constriction. So the contralateral eye will also constrict. This is called the consensual reflex. Usually this is what happens. Now once you swing the light to the other side, the same happens. Both the reflexes will both the pupils will um, constrict, showing meiosis. But if there's a problem in the one of the afferent pathways, what would happen is that now this is not conducted. Let's assume there is no complete dissociation as there is always there are few nerve fibers which might be spared, and somewhat the afferent pathway is not working well. Therefore, in this case, you would see if the light is shown to the affected side, the message or the stimulus will not be conducted well to the Edding-Westphal nucleus. So what would happen is that you would not the afferent pathway is bit deteriorated. Hence, the direct reflex will not work well. They will not work well. It is somewhat reduced. You would see a sort of a constriction, but the constriction is not sufficient enough, not as that of a normal eye. And also, the Edding-Westphal nucleus will send in a better sort of a stimulus to the contralateral eye. The contralateral eye, which shows the consensual reflex, will show the same will not show that much of a constriction, but better than the eye that is already been affected. Therefore, now both of these will somewhat constrict, but the constriction is greater in the unaffected eye. So you would see a difference between these two. If there's a difference, then uh, only in the presence of light. So there is an anisocoria only in the presence of light. So in this case, you know that there is a relative pupillary defect. So RPD. Since this is only evident once the light is shown through, so you know that this has something to do with the afferent pathway. So this is the afferent pupillary defect. Because it is relative between the two, you term it as RAPD. So are we clear? Usually there should be the the direct and the consensual light reflex from light reflex happening once a light is shown through. But if there's some sort of a disruption in the afferent pathway, in the afferent pathway, what would happen is that the direct reflex is more disrupted compared to the consensual reflex. It will happen because there are a few fibers which will always conduct, but it is not enough. It is not enough. Therefore, what you would see is that there is better constriction in the contralateral eye, or the consensual reflex is better than the direct reflex. So there is a difference between the two pupils. Hence, you call it a relative afferent pupillary defect. Are we clear? Then the other problem that we come across is uh, how this could be related in a reversal manner. Now, if there is no RAPD, you do a swinging light test and you see that there is no RAPD, then of course you should know that this could either be a normal patient who is having no problem at all, but if not, it could also be some other problems, because this could be either bilateral lesion, so there is no relativity between the two. Then therefore you wouldn't appreciate much of a difference between the two pupils. Then you wouldn't see the RAPD. Or else there are problems. It is not in the, now there could be some sort of a cataract or some other problem that is present, which will lead to the disruption of the light, but the pupillary pathway is not affected. Pupillary pathway is working. Then of course you wouldn't see the relativity between the afferent pupillary defect, because of course one eye wouldn't be working at all, because there is this uh, there is this what do you call the cataract or the obstruction. Or else it could be a problem that is present, the afferent pathway that is present beyond the lateral geniculate bodies in the optic radiation. So that will not affect, because the fibers that are carrying information to the Edinger-Westphal nucleus decussate or completely separates from the lateral geniculate body and will not have an association with the fibers that are conducted to the occipital lobe for perception. There is a problem. You wouldn't see. The patient says that there are visual losses. However, the patient will not be able to see, but still the consensual and the direct light reflexes are somewhat present, because it has no association with the the proximal part of the afferent pathway, as well as the other nerve fibers which are carrying information to the tectum or the midbrain. Or else it could be, now these are few circumstances where we would not appreciate the RAPD. Or else it could also be there are other problems. Now let's assume that there is a lesion in the tactile pathway, the nerve fibers that are carrying information to the Edinger-Westphal nucleus. So therefore, in this case, you would see a RAPD. But the patient does not, since the optic radiation is not affected, the patient will not say of any visual loss as such. So this is called a tactile RAPD. Are we clear? So if there is some sort of an disruption to the afferent pathway, so what would happen is that the direct light reflex would be altered, and the consensual will be disrupted as well. But of course, because of the differences in the conduction, you would see a difference between the reflexes, and therefore there could be a relative difference that is leading to a RAPD. Are we clear? If not, if the relativity is not there, it could be a afferent pupillary defect completely. When light is shown to one side, the consensual and the direct reflex will be completely absent, and when once it is swung to the other side, both the reflexes appears, which means that the side in which the reflexes was absent could be termed that there is a problem in the afferent pathway of that particular side. Are we clear? Right, so that is RAPD. So there are few. Now we have done the, what do you call, the hard part, and we are coming on to the easy components. Right. Now something very easy that you should know is now if you some patients who are coming to your clinical practice will show ptosis. So ptosis. Now ptosis means now one eye is not there is this it's the eyelid is almost converging in, it is closed in a mode of a closure. So this is due to the inhibited action of the superior palpebrae levator, superior levator palpebrae. I'm sorry, levator palpebrae. So this is under the action of the sympathetics. So in ptosis, you would see the disruption of the sympathetic conduction. Usually you see ptosis in Horner's syndrome. What is Horner's syndrome? Horner's syndrome is a condition where the sympathetic ganglions in the superior region are affected by different causes. It could be tumors in the lungs, it could be trauma, it could be there could be many reasons that could lead to Horner syndrome, but still infections as well. So tumors of the lung, there is something called Pancoast tumor which can lead to Horner syndrome. Now if there's a patient who is coming with ptosis, if it is unilateral, you should think about the possibility of Horner syndrome. So that is unilateral. If it is bilateral, then you should think about a systemic cause. Horner syndrome, of course, sympathetic pathway to a single or a unilateral eye is affected. Usually, Horner syndrome happening in bilateral is not very, it's not very possible. But if it is happening, if the ptosis is more or less bilateral, and if it deteriorates in the evening, then you should think about few other diagnosis. What are those? It could be myasthenia gravis. It could be Lambert-Eaton myasthenia. So these are myasthenia syndrome. So these are few problems. What is myasthenia gravis? Myasthenia gravis is a is a condition where you see there is two types, which is ocular myasthenia gravis, and of course there is the systemic myasthenia gravis. So in ocular myasthenia gravis, you would see the problem in myasthenia gravis is the presence of antibodies that has disrupted or destroyed the postsynaptic receptors for acetylcholine. So postsynaptic receptors are now absent. So will there be a conduction of the stimulus for a muscular contraction? No, right? So you would see that the muscles are not working well. This is especially prominent in muscles which require muscles which are working in longer terms. For an example, the eyelid muscles has to strain a lot because it is something that is kept working for the whole day long once you are not sleeping. So in this case, uh, if there are problems with the postsynaptic receptors, it will affect such muscles. Biceps, triceps like muscles, the thigh muscles, the hamstrings of course works, but the other muscles such as the bicep, triceps, and sometimes even the small muscles of the hand are not working as that much of where the eyelids. So in comparison, you would see such muscles deteriorating and showing manifestations. Looking back at the differentiation of myasthenia gravis with Lambert-Eaton syndrome, it's the fact that it's in myasthenia gravis, the antibodies are against the acetylcholine receptors. So anti-acetylcholine receptors uh, in the musculoskeletal junctions, in the neuromuscular junctions. But whereas in the Lambert-Eaton syndrome, The problem arises because of the fact that there is the presence of antibodies against the voltage gated calcium channels. Now there is this presynaptic neuron, the receptor for the muscle. So in this, the presynaptic neuron will release acetylcholine, which will bind to the receptor and causes muscular activation. In this case, acetylcholine is only released if there's an influx of calcium from the vicinity into the presynaptic neuron through the presynaptic membrane. But what happens is the voltage gate is somewhat destroyed by by the activity of the antibodies, and hence the pathway is not functional. Both of these can lead to the disruption of the muscular activity and thereby finally uh, leading to a sort of a dysfunctionality of the muscles that we term as myasthenia. But the issue is, now this has to be differentiated. There are a few problems. The problem can be, the diseases can be distinguishedly identified from one to another. Now, in the serological wise, you can do this by the identification of antibodies, the specific antibodies. In this case, you could see acetylcholine receptor antibodies, or else there is another antibody called anti-musk, or else sometimes if this is negative in serology to both of them, you can look for anti-LRP4. Now, of course, this has to be kept in memory. There is no other way. Now, this immunoglobulin is, or the antibodies are produced by a dysfunctionality or the altered function of the immunological system within our body. Now, if you can remember, thymus gland plays an important role in monitoring the immunological functions. If there's a tumor in the thymus, which is thymoma, this can lead to production of defective antibodies that can destroy the receptors, and hence you would see the consequence as the manifestation of the disease. So usually myasthenia gravis is associated with thym thymoma, but in Lambert-Eaton syndrome, this is not so. In this usual association with the lung tumor, that is called small cell carcinoma. Right. The physiological difference that we can usually identify between these two diseases is the fact that myasthenia gravis with repeated stimuli will show the manifestations. For an example, the ptosis can be triggered by repeated activity of the levator palpebris superioris muscle. In fact, if you keep on blinking, the ptosis would worsen. But in Lambert-Eaton syndrome, with repeated stimulation, it will actually improve. With prolonged exercise, it will improve. This is because of the fact, now with muscular activity, you would see the accumulation of you would see an accumulation of calcium ions in the vicinity that will lead to uh, extra secretion of acetylcholine, improving symptoms. But in this case, it is not so. With repeated action, the acetylcholine concentration in the presynaptic cleft would be reduced, and hence the manifestations would be greater. So this is what happens. So acetylcholine receptors, I'm sorry, the acetylcholine concentration will reduce with prolonged exercise. So what do we have to do? So we have to mitigate this problem by increasing the amount of acetylcholine that is present. This is done by either employing an acetylcholine esterase inhibitor, which acetylcholine esterase is an enzyme that will break down acetylcholine. So by inhibiting this, we can increase the acetylcholine concentration. So this is myasthenia gravis is pharmacologically treated by means of adding an acetylcholine esterase inhibitor. Are we clear? Now, another thing that I need to bring into focus or bring into attention is that now, usually the myasthenia gravis has many levels. It can cause problems. It can in the oropharyngeal region. It can cause ptosis. It can cause. There are many problems associated. The Lambert-Eaton syndrome is not so drastic as such, but still it has its own problems as well. But the pro that this both of these are quite similar to one another in many ways, but still you need to distinguish and identify them. So in this case, myasthenia gravis, if you look for deep tendon reflexes in myasthenia gravis, this would be there. This is because now, as I said, in myasthenia gravis, the problem is not with the absence of acetylcholine. In fact, the acetylcholine levels are quite normal. The problem is with the repeated stimuli, with repeated action, the amount of acetylcholine will reduce, and therefore the action on the viable receptors will decrement with time, and hence there will be dysfunctionality of the muscles. So, if there are now the amount of viable receptors are low, so you have to keep excessively high amounts of acetylcholine to compensate. But if the acetylcholine levels are low, then the problem will be of course evident in the patient. Now in deep tendons, you are doing now deep tendons are not quite active as such as that of the uh, eye muscles, which are very active throughout the day, throughout when you're not asleep. So in this case, by single stimulation, you wouldn't see that much of a difference. So you once you go through the examination and do a tap to the deep tendons, you wouldn't see that much of a difference. And therefore, but in Lambert-Eaton syndrome, the problem is the acetylcholine levels are low because there is not enough of influx of calcium, and hence even though you tap on the muscle to cause a deep tendon reflex, the amount of acetylcholine is less, and hence there will be not much of a motion that to be appreciated. Did you are we clear on that? So deep tendon reflexes are quite preserved in myasthenia gravis, but not so in Lambert-Eaton syndrome. So this is how you usually identify the problem. So uh, correlate with the manifestation so that you can clarify the problem, clarify the disease, and come to a conclusion. So now we'll move on to the next segment of our lesson. So as I mentioned, anisocoria, which means there's different sizes of pupil. Isocoria means the same size of pupil, whereas aniso means that it's no longer no longer composed of the same size. So different size of pupils could be due to two problems. It could be either the inactivation of a sympathetic system, which we call as Horner syndrome, or else it could be a problem usually associated with the parasympathetic system, which causes constriction of the pupils. So parasympathetics, dysfunctionality of the parasympathetic. Right. So one of the most critical component in an ophthalmological study, once you see such anisocoria from happening, what you have to do is that you have to distinguish what the issue is. So in this case, we would like to do few pharmacological testing to identify which sort of a problem that the patient has. Now in this, what I would like to do is that if initially if this is to be an Horner syndrome or a malfunctioning of the sympathetic system, then I would like to confirm it. How do we do that? It's actually initially as a part of a commencement. What you can do is that you can use a direct source of a light and see what happens to the anisocoria. If the anisocoria is greater in dark, greater in dark, which means now when there's no light source, the dilation, the difference between the dilation and the constricted pupil is greater, which means the problem is probably within the sympathetic system. Why do I say so? It's because now in the dark, what happens is that usually what happens is that there's the dilation. So both of these pupils has to dilate, but one of it is not dilating enough. That's the usual problem. So the inability to dilate is probably due to the malfunctioning of the sympathetic system. Hence, now I have confirmed that this is a problem within the sympathetic. So probably could be honest. Now, if you can remember your neuroanatomy, the pathway to the dilatory, the radial muscles of the pupil is quite long. It has three neurons, initially starting from the hypothalamus, and then it goes to the spinal cord. It is the uh, C8 T1 level. In fact, it could also be T2. So the spinal cord, and then to the superior cervical ganglion of the sympathetic chain, and then into the pupil radial muscles. Now there are three orders of neurons. This is the first order neuron, this is the second, as well as this is the third. So there should be a malfunctioning in any of these which has led to Horner's. So we have to identify distinguishly which is the problem. So in this case, we'll use few sympathomimetics. What are the sympathomimetics that you know? One thing would be cocaine. So we can use topical cocaine to see whether it actually dilates. If it is so, if it shows response, cocaine is a sympathomimetic, it causes activation of the sympathetic system. If cocaine causes dilation of the constricted pupil, then you are confirmed that it is actually a Horner's syndrome. But the problem lies where the problem is. So there are three orders of neuron. You could have a malfunctioning in either of these. So what you have to do is that you then use actually it's another sympathomimic as well, but this is called hydroxyamphetamine. What it does is that amphetamine, what it does is that it reduces the reuptake of noradrenaline. If you can remember, there is norepinephrine is the one that is being acting in the preganglionic in the preganglionic part of the pathway, and here there is the action of receptors from alpha 1 and alpha 2, particularly alpha 2. Now once hydroxyamphetamine is introduced into the system, what it does is that it causes activation of the preganglionic neuron. Now in this case, if it becomes dilated, then you know the problem is within the preganglionic part of the neuron. If not, you can say easily that it is actually the problem in the third or the third order of the neuron. Now, the other now, so cocaine can use to distinguish or identify Horner's syndrome, whereas localization is carried out by hydroxyamphetamine because it causes reduction of the reuptake of norepinephrine. What else? Then, of course, there is the other test that we can use, which is pilocarpine. No, in prior to that, we have to go through. Uh, there is apraclonidine, Apraclonidine is an alpha 1 agonist. The problem with the Horner syndrome is that usually the pupil muscles or the radial pupil muscles are activated by means of alpha 2. But in Horner syndrome, what happens is due to the compromisation of the sympathetic flowway, the alpha 1 receptors predominate because there is this the alpha 1 tries to compensate for the lack of activation of the alpha 2, and so what happens finally is there's uh, uh, large concentrations of alpha 1 receptors residing uh, in the in the muscular pathway, making sure that the if there's any sort of a sympathetic flow coming into it, it will respond. So by using apraclonidine, which is an alpha 1 agonist, what we can do is that we can stimulate the alpha 1 receptors and thereby cause dilation. So by doing this, we can come to the confirmation that if the constricted pupil shows some sort of a response towards apraclonidine, then yes, you know that this is actually a Horner's pupil, and the anisocoria is due to the lack of the sympathetic pathway. Right. Then we have to come to the other possibility. Now, the anisocoria is greater in light, which means now usually in light, what happens is that the pupils constricts. The problem here is that one of the eye fails to constrict. Now you know that this is an issue within the parasympathetic pathway. So in this case, what we can do is that uh, we can see we can use a slit lamp as well to this to identify this, but we can use pilocarpine. Pilocarpine causes, once this is utilized, what would happen is that the affected eye will dilate and respond. So pilocarpine is the agent that is used here. What would happen is that it will reduce the functioning of the parasympathetic pathway and thereby causes some sort of a reduction in the anisocoria. So this is what happens. This is what you should know when it comes to anisocoria. Are we good? So the three, you first shine a light and see whether whether there is any sort of a difference in dark and light. If it is in dark, then yes, it's a problem within the sympathetic system. If not, it is a problem that is usually associated with the parasympathetics. So if it is in the sympathetic, what you can do is you can use cocaine, use hydroxyamphetamine to confirm as well as localize the issue. But in if it is greater in light, then you can use pilocarpine to confirm and to remedy the issue. Right. Now, of course, now you know about anisocoria. The other thing that I would like to emphasize or go into is actually now this again is a little bit of a tricky topic. Another condition that we come across in some patients that we see in our day-to-day ophthalmology practice, it is actually skew deviation. Now here, what happens is that you see once a patient turns his head, you see a sort of a disalignment in the pupils, not in the pupils, but in the irises. So there will be something like this. It's now usually the normal circumstance has to be known prior to this. Once we tilt the head to one side, let's assume that we tilt the head to the right. What happens is that now once you tilt the head, now there are these two eyes, the vision has to be brought back to the level that it was prior to this movement. So what happens is that the uh, uh, the irises usually turns so that it is brought back to the initial state, so that it comes back to the midline. So in this case, the right eye or the ipsilateral eye would intort, and the contralateral eye or the left eye would extort. This is the normal phenomena that we see in changes of neck position as well as the head. But in skew deviation, what we see is that this does not happen. In fact, it is the opposite. You see that the right eye is coming to the extorted position, whereas the left eye would probably show a intorted one. So it is not present in one, not present in a very aligned manner. So this happens because of the problems that arises within the vestibular complex as well as its pathway. Now you should know the neuroanatomy. There is this vestibular complex, particularly in the utricule as well as the semicircular canal, which provides constant innervation and stimulation to the hindbrain, especially the midbrain as well as the pons, communicating it with the cranial nuclei of the sixth, the third, as well as the fourth. Now, what happens is that it speaks directly, in fact. So, what happens is that initially there is this in the midbrain, in the mesothalamic junction, you get the vertical gaze center, which comprises of the third as well as the fourth cranial nerve, the nuclei of the third and the fourth cranial nerve. So what does it do? Now, in fact, the third one, the third will control the inferior oblique muscle, whereas the fourth will carry out actions of the superior oblique. So in this case, if it has to undergo some sort of an intorsion or an extorsion, by utilizing these two muscles, it can carry out the process. So what happens is that now, if by any means the vestibular complex uh, communication with the vertical gaze center is disrupted, what would happen is that it will not function well. Now, there are a few other structures of the brain that are associated with this, you might know. Now, this communicates via the medial lemniscus, and also associated to these centers, you would find the interstitial cells of Kajal. Uh, in fact, it is called, it spells Kajal, but it's Kahal, interstitial cells of Kahal. Right. So these are the structures that are involved in this. So for the proper functioning, everything should work in a very smooth manner. Now the problem is, now if there's any sort of an issue, now I'll be drawing this. This is the head. Then this is the ear or the vestibular complex. Nerves coming through that will cross immediately, passes to the midbrain. You would find the vertical gaze center. So this is the vertical gaze center. So by any means, if this is not working or this is disrupted, this is the left side. So what the midbrain perceives is the fact that there is some sort of a motion. Now it doesn't identify the fact that the left side is not working, but it sees that the right side is more functioning, which means now it assumes that this, even though the patient has not turned his head, but it assumes that the problem is with there is some sort of a difference between the communications that is coming through the medial lemniscus of the right side as well as the left side, but the left side is less, the right side is greater, so it assumes that the right vestibular complex might be active because of a head tilt, which is not actually there. So it assumes that the head is in a tilted position to the right. Hence, it activates the vertical gaze center and causes the changes that are usual in such circumstances. In this case, what it does is that it causes the right eye to intort as well as the left eye to extort. But if this is seen in a normal person, then we know that this is bit this is deranged, and this is not something normal or what we are accustomed to see. So hence what you see a disrupted sort of a eye alignment where one eye would be up and above in an intorted position, which is the right, and the other would show somewhat something below, something that has been depressed and extorted, which is the contralateral eye. Usually what we once we once we provide terminology, we give terminology according to the eye that is in the lowermost position, which is in this case the left eye. So this is a right eye, right, this is the right eye, which is in a hypotropic state, which means that it is below. No, I'm sorry, it's not the right eye, it's the left eye which is in a hypertropic state. So you term this as a problem in the right side, so right side lesion. In fact, it is actually a problem in the left vestibular complex, but still the lesion would probably be in the right medial lemniscus. Are we clear? Right. So this is the sort of skew deviation that you come across. Again, something very important and very difficult to understand. Now, uh, other thing that you might come across, now there are patients who have fourth cranial nerve palsies. What does the fourth cranial nerve do? Fourth cranial nerve uh, controls the superior oblique muscle. What does the superior oblique do? Superior oblique carries out, it is a depressor as well as a muscle that causes intorsion. So in fact, the eye would be in a upward, it has actually elevated and in an extorted manner. So this is the eye that you would see. But the problem is now, if you need to clarify whether the problem is with a fourth cranial nerve palsy or else it's whether it's a skew deviation because of a impaired vestibular ocular reflex, then what you can see is, so you can appreciate very well that fourth cranial nerve is usually unilateral, and or there's only a disalignment of a single eye. But when it comes to skew deviation, problem within the vestibular ocular reflex, then the problem is bilateral. So by using this, you can easily identify and differentiate a fourth cranial nerve palsy from a skew deviation. So easy as that. Are we clear? Right. So finally, uh, this is the final one that I would like to go through, which is the visual field defects. Again, something very important, and sometimes you have to do a visual system examination. You have to find whether, once you're going through this, you have to do an examination of the visual acuity and also the field as well. That is something that you need to clarify and see whether there is any problem with it. By coming into a conclusion, you should know that whether there are any disruptions as such, right? So here there is this visual field defects. I'm just going through them in a very quick manner. because this is something very easy that most of you understand. Now there are two fields, the nasal field and the temporal fields. The nasal field will I'm sorry, the nasal part of the retina and the temporal part of the retina. The nasal part will be looking at the temporal field of the particular eye, whereas it's vice versa when it comes to the the lateral most part of the retina. Are we clear? Now, if there's a disruption in the optic nerve itself, it causes problems where both the medial as well as the lateral half of the optic nerve, which conducts information from the total retina, is however compromised. In this case, this can happen due to many conditions. There could be inflammation of the optic nerve, it could be optic neuritis, or else it could be a simple glaucoma. So in this case, what would happen is that, or else the retina would be malfunctioning as well. So retina could undergo detachment. There are many things more than this, but by any case, if this is not working, you will the one of the eye will not be functioning. So it is complete anopia of a particular eye, of the disrupted eye. It could be left, it could be right. Are we clear? Now, if the problem is in the optic chiasma, where the medial parts of the eye crosses one another, usually this happens because now very close to this you get the pituitary. If there's any tumor in the pituitary, or of that of the or a regional tumor such as a craniopharyngioma, which is the structure which gives rise to the pituitary. In this case, it will compromise the nerve fibers that are crossing over, which will lead to, now since it is uh, the medial part of the retina that is being jeopardized, therefore you will lose the visual functions of the temporal region of the eye. In this case, it could be it could be both medial and it could be both bilateral cases. Both right and the left eye would be involved. Hence, there will be bitemporal hemianopia. Are we clear? Now, after the optic chiasma, you get the optic radiation. In the optic radiation, initially it moves in a very it moves without any division. It comes as a continuous and a complete flow. What would happen is that if there's any disruption as such, now this includes the lateral part. In for an example, if I illustrate the right optic radiation, this includes the fibers that are coming from the lateral part of the right eye as well as the medial part of the left eye. In this case, what you would see is that there will be uh, hemianopia, because one of the part is not working well, but still it would be a not a temporal one but a homonymous, because it is present in, because once evaluated separate to one another, you would see problems within in a single aspect of both the right and the left eye, but it is in the same side. Therefore, you could see that this is a homonymous hemianopia. Are we clear? Usually, this happens because of a, now this is in close association with the middle cerebral artery, and also it is been in a perfused by the middle cerebral artery. By some means, if the middle cerebral artery becomes occluded, in this case, you might see disruptions of the optic radiation leading to homonymous hemianopia. Are we good? Right. Right. Now, after proceeding with the optic radiation, what you would see is that the optic radiation usually divides into two loops. These are given the name. There's one which is passing in a more temporal manner, to close to the temporal lobe, whereas one passes close in association with the parietal lobe. So there is these two, which is the Myers loop and the Bounce loop. So these, since it is separated from one another, each of these has an individual potential to become disrupted. If the Myers, which is the temporal as you know, now the optic radiation only accounts for half of the vision, half of the field of a particular eye. Now even that is now separated to two lobes. The Myers, or the one that goes below, or the temporal, close in association with the temporal lobe, will account for the, I'm sorry, the, oh yeah. So Myers, which goes below to the close to the temporal lobe, will account for the upward part of the field. So if there's any disruption of the Myers loop, it will cause superior quadranopia. Are we clear? Usually this happens because of a temporal tumor. Uh, so if the Myers loop is jeopardized, then you would lose the upper part of the vision, the upper quadrant of the vision. Vice versa, you would see the if the Bowes loop is affected, it could lead to a loss of the inferior quadrant. Are we clear? The other, now after passing through the lobes, it will coalesce back again so that it goes to the occipital lobe. Now, if this is the visual cortex, the problem with the visual cortex is that now the macula, or the area which is provided with the most concentration of uh, visual sensitive receptors, is in fact controlled bilaterally. So if by any means, if the visual cortex is disrupted by some sort of an infarction, this could be an infarction. So what would happen is that particularly the infarction is possible if the posterior cerebral artery is occluded. So in this case, you would lose the field of the particular area, the area that was provided by the optic radiation, but the macula would be spared because the fibers of the macula is in fact uh, sensed or perceived in a bilateral manner. Are we clear? So these are, if you have to do a visual system examination, um, go through there are few things that you have to do in a normal cranial nervous system examination. So by doing that, you have to assess the visual acuity, the field, as well as the colors as well. So there are these charts to identify colors. So by doing all these, if once you are pretty happy with the field, or if there's any disruption you have identified, make sure that you localize the lesion and think about the possibilities that might have led to this particular consequence. Are we clear? Right, so this is the first part of the neuro-ophthalmology video that I'm doing. Preferably this again, I know that this is something that is very difficult, and you might find it uh, bit not easy to understand. So better go through this in a very relaxed manner and see whether there's any other lack of knowledge, particularly in the neuroanatomy section, that you need to reiterate. And by doing so, if there is deficits that you need to fulfill, yes, go through your books and then see whether just an outline. I just wanted to see, I just want to do it in a very in a more or less a clinical manner, so that you will identify the problems that are associated with neuroophthalmology and try to link it with the neuroanatomy that you have already learned. So thank you. We'll be meeting back with the second part of the neuro-ophthalmology lesson that I'll be preparing.